So I never know if I should say good morning or good afternoon, or just good noon. It's an awkward thing to say right at this time, but hey everybody, um, thanks so much for being here. I know it's always the platitude that speakers say when we first, kind of get to the podium, but um, for a variety of reasons. I mean, I know you're busy people. Some of you, you're driving places. You got to eat your lunch. You got to do whatever. That doesn't hurt my feelings at all. Please take care of yourselves. I'm just glad that you're willing to step into the space and have this conversation and let me be here. As you all know, if you attended the last one, in addition to many of the other things I get to do, I'm a person with lived experience, and I'm a really firm believer, and my belief in this grows day after day, that people who use drugs and people with lived experience should have a real voice in the development of programs and policies that impact them. And so in addition to getting to be like a scientist in these spaces, I also get to be kind of an advocate. And so uh, I'm, I'm just grateful every time I get a seat at the table. Um, and I'll give you a quick introduction on who I am, maybe a quick recap on what we did in part one, just in case you have entirely forgotten or you didn't have the chance to attend, and then we'll kind of dive into today. Um, So, yeah, my name is Alex Ellswick. I'm currently an associate professor and extension specialist at the University of Kentucky. And if you aren't familiar with cooperative extension, I'll spare you the big explanation, but it means I have a cool job. In addition to doing traditional faculty work where I teach in the classroom and where I teach on substance use disorder and drug policy and related issues. I'm also a researcher, and most of my research focuses on harm reduction and substance use in families. Um, but it means there's also a third leg of my job, which honestly is quite a lot like what we're doing here today, which is basically research translation. So instead of just staying in the ivy tower, the ivy tower, so to speak, a lot of my job is to kind of build the bridge and translate the research and put it in the hands of practitioners, people like you all, people who can use it to good effect. And so it's yet another reason why I'm grateful to have an opportunity to be in this space, because it really is the nature of my job. Um, I'm also a co-founder of Voices of Hope, and this is my only 15 seconds to make shameless plug for Voices, but we're a recovery community organization in Lexington, Kentucky. We're entirely peer-based. We're the first and largest in Kentucky and one of the largest in the country. So we have about 85 staff, all of whom are not LCSWs. They're not doctors. They're not credentialed in any particular way. They're people with lived experience. And that is really the predicate for everything that we do. Um, it's also a place where we've just built a really cool community, and we do really innovative harm reduction work, and be happy to share about that or talk more about that if we have time. But um, so in addition to that, I also have a little bit of a clinical background. I actually started my professional career as a marriage and family therapist. I wanted to work with families who'd been impacted by addiction the way that my own family had been impacted. I learned in short order that I was really bad at it, which always sounds like a joke, but it's not. Um, and and so, in addition to all that experience, I think most importantly, what I have is lived experience. And I'm not gonna, I know I shared, probably the 5-minute version last time. I'll give you the 30-second version this time, just to reiterate how it brings me to Recovery Capital. But I grew up really privileged, but I also grew up with inheriting risk factors for substance use disorder. I have a long family history of substance use disorder. I also have multiple co-occurring anxiety disorders. Um, and those didn't get diagnosed and certainly not treated until I was in like my second inpatient treatment center. And so when I was 18, I got prescribed opioids. I developed an opioid use disorder. Um, I went in and out of treatment and in and out of treatment. And the story that I was told, the instruction I was given about what recovery looked like was I just needed to go to treatment, and I needed to go there was this clinical attitude that was like, well, addiction's a disease. So what you need to go do is treat your disease. And you'll go to this place for 30 days and it's not entirely clear what we mean when we say the treatment, like what specific intervention is the intervention that's being applied. But in any case, you're going to go to this place for 30 days and we're going to sort of sanitize addiction out of you. And at least that was the understanding um, that I took. And so I went in and out of treatment so many times and tried in earnest. Um, and there's so much I could say about that, but I always want to reiterate that I was trying so hard to stop, and I would get out every time, and the instability, just the sheer instability of my life, um, led me to relapse over and over and over again. And it wasn't until just as a matter of like happy accident that I kind of tripped and stumbled and fell into a continuum of care that approximated a kind of stability that allowed me to actually build on some of the assets that I already had, and just to go back and get an education and to develop a career and all the things that make, have a home and a relationship. Um, and so I've just over time, I've really become obsessed with this notion. That's what we call recovery capital. I really became obsessed with this notion that here's what I became obsessed with. People don't stop using substances if and when you treat it out of them. That was the understanding I had initially. And I think a lot of the message that we get, oftentimes maybe the medical community is complicit in sending that message, and I'm not trying to point fingers, I'm really trying to be part of the solution. But um, you know framing addiction as a disease did so much good for so long, because it really did help reduce stigma, and it did help shift the perception of blame and the locus of control. But there are limits to it. And we could have that like conceptual debate another day. I actually mean for this to be less abstract than last time. um, but it really does proffer this idea that this is just something that we treat out of somebody. And the lesson that I learned from my own experience, and that I've continued to learn through research and through my on the ground experience at Voices of Hope, is that people stop using substances when it makes sense for them and for their life. That people, as trite and hackneyed as it is, really are experts in their own lives. And they really, really will stop using substances at a time when that makes sense for them. Um, you know, when they have the stability to sustain some kind of remission. And so um, I'm going to give you the quickest of primers on recovery capital, because I know for most of you, if you were here last time, we talked about this. I don't mean for this to be nearly as didactic as last time. So this is a little bit of academic. Then I'm going to tell you a story to kind of use as a case study, and just get your thoughts and your feedback. Um, you know, to me, everything about recovery capital is not novel. I use that term, and that probably makes it sound kind of esoteric or niche or something. But really, what we're talking about are meeting basic needs, holistically meeting basic needs. You can think of them as social determinants of health. You can think of them through the prism of Maslow's hierarchy, whatever it is. We're saying like the expectation that someone is just going to become abstinent and be treated out of a substance use disorder without meeting all the basic needs, without meeting the basic determinants of health, is really kind of a wild notion. And for people who use drugs and people with substance use disorders, it becomes like an offensive notion and kind of a traumatic notion. And so, Maslow said, in order to reach your full potential, your needs have to be met, and they have to be met in order. Um, and so that's intuitive for most of us. Like, you wouldn't send your kid to school in the morning and ask them to perform well if they don't have breakfast in their belly and if they don't have a good night's rest, right? Like, that's you don't need to read the parenting magazines to come up with that. You just know intuitively, my child needs to have their basic needs met. And then I always give the example of, and sorry, I'm so nasally. I just got back. I had the chance to lead a study abroad program to Portugal and got bronchitis on the way back. And like, I sound goofy, so sorry. But I always give the example of when I was experiencing homelessness in my addiction, you wouldn't have pulled up next to me in your SUV and leaned out the window and said, "Hey, buddy, you just need some self-esteem. Hang in there." I mean, we all would agree that yes, I needed self-esteem, but in order to build self-esteem, I needed like the predicate of maybe like somewhere to sleep other than under a bridge, or I needed a nutritious meal, or I needed wound care for the abscess on my arm, you know? And so a lot of that's intuitive, but part of what I want to underscore with this case study and this example is we tend to lose sight of it. We kind of pay lip service to the need for recovery capital, or um, meeting some of these basic needs, whatever language you want to use. Um, and so, and I think a drug court is a really good example. And again, it's not to point fingers or to be critical. It really is to try to just underscore this point. So I want to tell you a story about my best friend Bobby. And first, I have to acknowledge, and this just feels like classic guy stuff to me, but this is my best friend. I don't have a picture of him readily available. I know I have a picture with him. He was the best man at my wedding, and I promise I looked, but sooner than I found that, I found a picture of our daughters together. So um, this picture was taken in summer of 2024, about 3 months before Bobby was sentenced to 7 years for trafficking. And to the left, our right, is my soon to be 10-year-old Gracie. And to the our left, their right, is his daughter Maddie. I'm not sure how old she was at the time. And this is a camping trip that we took, like I said, just a few months before Bob got tried and sentenced. And Bob is my go-to when I think about recovery capital, because I think about all of the blame and the shame that he wears all the time, and how much of it is a consequence not of a lack of motivation or a lack of desire to be healthier or happier or to be a stable source of support for his family and for his daughter, but instead a consequence of a real stark lack of recovery capital. Um, and so I want to just think about Bobby in the context of recovery capital. And so I share all this with permission, first of all, and it's going to sound harsh, but I mean it. You have to know that I love this person. This is blood to me, you know. Bobby is he's kind of short in stature. He's about 5'3". When he was really young, when he was like 2 years old, his grandmother's dog attacked him, bit his ear, and so he has a really bad scar that runs up the side of his head that he's been self-conscious about since we were kids. That I have to imagine affects his self-esteem, that affects the way that he interacts socially. Um, Bobby has a learning disability that emerged at a pretty young age and became apparent. It might be a form of dyslexia. He has trouble with reading. But the point that I want to underscore is it means he got left behind in school. And he got left behind really early, and then he got shuttled through and shuttled through. Um, and of course, that impacted his self-esteem, but it also meant it impacted, ultimately his education and his earning potential, his job opportunities, et cetera, et cetera. He had Maddie when he was relatively young, and he is not in not no longer together with her mother, and so he's navigating a blended family and co-parenting across when he didn't have basic parenting skills to begin with, due in part to his young age and due in part to just kind of quasi family support. I'm not just trying to tell you a sad story. I'm just telling you this is my friend Bobby. This is his life. He has PTSD that's untreated, and also what I'm quite confident is untreated ADHD. And I also think it's part of the reason why he finds himself so attracted to stimulants. I think it's a part of trying to scratch the itch for what should be a prescribed medication. Um, and a couple of years before that picture was taken, Bob got caught on a possession and a paraphernalia charge and got put in drug court. And drug court to me was a really good example of a genuine effort to build recovery capital that just doesn't quite land, that didn't quite translate because it was too explicitly focused on demanding that he get abstinent and not letting him um, build the capital that he needed first. forcing him to be abstinent in order to earn capital. And so, I like to think of, I like to think of recovery capital as scales, to kind of double down on this notion that people don't just stop using when you coerce it out of them or punish it out of them or even sanitize it or treat it out of them, but instead that people recover when it makes sense for their life. Um, and so when you're thinking about Bobby, he has some assets. And I think it's important not to understate the fact that even someone who might seem to be in dire circumstances like Bobby has some assets upon which you can build. And two of them are he has a real motivation, a motivation for his recovery. He's pretty miserable. We talk about how people need to be sick and tired of being sick and tired, and indeed he is and has been for a long time. I don't know that he has a clear motivation for abstinence, but he certainly has a clear motivation to be happier and to be healthier. He also has a really authentic motivation to have a relationship with his daughter, whatever that looks like. However, it looks like being involved in her life and being able to show up for her to the fullest of his capacity. He also has some family support, some measure of family support that might be surprising given how long he's been had an active substance use disorder. But on the other side of things, he has a lot of liabilities as well. And this is the short list. This is by no means the comprehensive list of the deficits that he faced. And so when you think about it through this perspective, um, it it becomes kind of painfully obvious. I should be able to like animate. Sorry, excuse me for just a second. Let me okay. If I wish I could animate this so you could see like what it looks like when when all the scales turn to one side. Because what you're asking people to do in most of these cases, what drug court was asking him to do is abstain, is to stop using substances at a juncture in his life when it definitely didn't make sense to him. It definitely didn't fit with the conditions and the circumstances of his life. And so the way that drug court responded, and I know they respond in good faith, and that's why in every space when I give this example, I don't want to just sound critical. I know this is done in good faith, but I think it's a misguided over prioritization of abstinence, because what they did was they asked the question, how do we get Bobby to stop using? Right? That was the simple question, is how do we get him to abstain? And so weekly drug screens with associated punitive sanctions that ultimately included going back and serving the sentence that was supposed to be suspended in the first place. So it always riles me up when we say like, oh, this is an alternative, a progressive alternative to incarceration. And you're like, well, yeah, except for people who have relapsing substance use disorder, it's not going to be an alternative to incarceration. He just ended up incarcerated anyways. But it was entirely predicated on abstinence. And so it was saying like, yes, we want to encourage you to get a job. So they recognized the need, the deficit that he had in terms of vocational training, in terms of earning potential, in terms of career development. But instead, what they said was, you need to go get the first job you can get. They put, right? That's the pressure, the levers that were pressed on him. And so he went and got a minimum wage job flipping burgers. There's no way that's the shovel that's going to dig him out of the trouble that he's in. Um, they recognized that he had a need to treat his um, ADHD, but they would only give him non-pharmacological solutions because drug court didn't want to introduce at that time a pharmacological intervention, which means he probably wasn't getting the mental health treatment that he actually needed, that was actually indicated. Um, so it's not that it's a half-hearted measure, because I think that's an unfair criticism. I know everyone's hearts are in the right place. I just think it's a little bit of, again, this over prioritization of just demanding people just get abstinent, just choose abstinence or be treated into abstinence without acknowledging that all of this stuff is predicated on the foundations of health and wellness. So what I'm kind of, using this as my case study to explore is, how do we shift the question from how do we get Bobby to stop using to what would Bobby's life need to look like in order to sustain recovery? And in a lot of ways, it truly wasn't until I just was putting together these slides that it occurred to me that in a lot of ways, that's like the trauma informed shift. And I know in every space, we've all, rightfully so, been hit over the head with trauma informed trainings and this and that. And, the ethos that I hear from those a lot is how do we shift from what's wrong with you to what happened to you? Um, and this is a similar version, maybe a little bit more zoomed out, but how do we shift from what's wrong with you to what do you need? You know, what are the deficits that aren't being met? And so here's my question to you, just to start off this conversation. It's a thought experiment, but it's also genuine. If you had $10,000 to spend, what are the three things you might focus on when you're thinking about Bobby's life? I mean, would it be expanding to enhanced drug screening so that you can account for, you know, um, psychedelics and synthetic cannabinoids to make sure that he's really not using anything? Um, is it going to be, would you spend that money to incarcerate him with greater sanctions? Or would you spend that money to address any of the litany of needs that he has? Um, and maybe it seems like an unfair question, but I think ultimately it is the question that we're faced with. We've spent, God knows, untold amounts of money trying to address Bobby's substance use disorder. And by we, I don't just mean his family or me. I mean all of us, taxpayers, Kentucky taxpayers, have paid an awful lot of money to support that. And and when there's this inherent mismatch between an acute treatment um, for a chronic disorder that's really a lot more complicated than just something that can be treated or sanitized. I think it's just a mistake. So here's my cheesy. I feel like I got to leave you with a cheesy metaphor. So here's my analogy. It feels oftentimes, or it felt to me like what drug court was saying to Bobby was cross the river. This is the Rhine. This is your crossing the Rhine, crossing the Rubicon, whatever it is. You it's your responsibility to have the resources to get across. And in fact, in this case, a lot of times what we're saying is many of the resources that you'll need are just across the river. Just get across and you can have them instead of, how do we build a bridge to get you there? So one of the things that I'm encouraged by is that like at the University of Kentucky in our hospital system, we're starting to integrate things like social determinants of health into standard screening. So, and it makes so much sense as a basic part of, like checking, have you had any chest pains lately? We're also checking, like, are you stably housed? Which is so simple, but so important and so overlooked. And then developing these systems around warm handoffs, incorporating peer support, making sure that we're really meeting needs. I'm excited for other people's excitement around recovery capital or whatever they want to call it. I'm excited for just kind of what feels like a lot of people awakening or people who have been there already. A lot of you have been doing this work for decades and have long been at this place of saying, what good does it do to pay for 30 days of specialized treatment for someone who's going to return to go under a bridge on the other side, right? It's offensive to the clinicians and offensive to the person who's struggling. So um, yeah, so I figure I'll stop there for today. I wonder just what your experiences are with this, in particular with trying to build recovery capital. I think sometimes the question, I guess, for clinicians is, but what's our role? What role do we play? Because, in oftentimes, depending on what capacity you're working in, you may not be a social worker or a case manager. Um, but I wonder what that looks like in the systems in which you work. Are you all using peers to make those connections? Are you developing systems for warm, referrals and warm handoffs and that kind of thing?